Namaste, my dear brothers and sisters. The love and blessings of the Mother and Sri Aurobindo to all of you from Sri Aurobindo Ashram Delhi branch. We go to today's topic. Unlike the systems that we have talked so far, reproduction does not by itself uh, contribute to homeostasis. It does not help in giving the cells the type of environment that they need for their survival in terms of the temperature, the acidity, and the warmth, and the saltiness, etc., which we have been talking about, which are the essential conditions in the immediate surroundings of every cell of the body for these cells to be able to function properly. With that, the reproductive system does not make any direct contribution. But at the same time, it is important because no matter how perfectly we are made, our life is limited. And therefore, it's important that for the species to continue, we leave behind our own kind. And that is what is ensured by the reproductive system. So, in that sense, reproduction is no less important than the other systems because if the species has to continue, then this process of replication, this process of reproduction is important. Normally, while talking about the reproductive system, I have been talking, and probably that is the usual pattern in books also, about the male reproductive system and then go to the female reproductive system. And the justification, or you can say whatever was given for that was, let's get the men out of the way first and then we turn to the ladies. But this time I decided to follow the dictum ladies first. So you can see that you can justify everything. You can justify talking about the male reproductive system and first or the female reproductive system first. And one reason why I decided to do this was because we have two consecutive sessions today and tomorrow. So I thought the continuity of the female reproductive system might be better instead of having a long gap between two sessions about the female reproductive system. So what we'll do is we'll have our session today, which will focus on the menstrual cycle, the physiology of the non-pregnant female. And this is sort of the periodic bleeding, which women experience once a month for a few days. All bleeding essentially is abnormal, except this bleeding. This bleeding, which includes not only bleeding, but also shedding some debris from the uterus, is something that happens as a part of the normal process. And therefore, while bleeding in general is abnormal, this is an exception. And this bleeding that takes place in the fair sex during the fairest phase of its life is considered normal. So with that, we go to the PowerPoint. We're going to understand now the cyclic bleeding in women, which is the menstrual cycle. But before I go further, this course and all the activities under the YES project are a part of the 150th anniversary celebrations of Sri Aurobindo and the 75th anniversary of India's independence. Let's have a look at some of the basic terms, the bare minimum that is necessary for understanding this physiology or the functioning of the reproductive system. The sex organs, the basic sex organs are called the gonads. And in the female, the gonads are the ovaries, and in the male, the testes. These gonads have two functions. One is to form the sex cells, or what are called gametes. In the female, it is the egg or the ovum. The plural is ova. And in the male, the sperm, sometimes also written as sperms, but sperm itself is also treated as a plural. And if you want to go to the fuller, more impressive name, it's a spermatozoon is singular and spermatozoa is the plural. But we shall by and large stick to the simpler term sperm, both as singular and plural. And Then the second function of the gonads is to manufacture sex hormones. In women, there are two, estrogen and progesterone. In men, there is only one, testosterone. So that's what perhaps makes women a little more complex, two sex hormones instead of just one. And that reminds me of that song from, what was that, My Fair Lady? Professor Higgins, I think the star was Rex Harrison, is singing that song. Why can't women be like men? Men are so simple, huh? Something to that effect. So they're simple because they have just one sex hormone, the testosterone. Now, the regulation of reproductive function. This is the general scheme. And here you would recognize the same type of arrangement as we have seen in the case of the thyroid or the adrenal cortex. Now, here are the gonads with these two functions, manufacturing the gametes, which are the basic cells which unite to uh, give us the beginning of a new life, and the sex hormones from the gonads. Now, these sex hormones are to some extent, in fact, absolutely essential for forming the gametes, and therefore this arrangement is understandable. But then the sex hormones are not, the function of sex hormones is not limited to helping us form these gametes, the eggs and the sperms in the gonads. The function of the sex hormones are manifold, and one of them is the secondary sex characters. You know, when child starts manufacturing more of these sex hormones around the age of 15, then you find that there are certain physical as well as emotional changes, and these are all the result of these rise in the levels of these sex hormones. So they have other functions as well, the sex hormones. And the function of the gonads uh, in terms of manufacturing the sex hormones is controlled by the anterior pituitary. And corresponding to these two functions, we have two hormones from the anterior pituitary which regulate the gonadal function, FSH or follicle stimulating hormone. This stimulates the formation of the gametes, and it's called follicle stimulating because the uh, histology, so the name that we give into that microscopic structure which forms these gametes is the follicle in both men and women. So this follicle stimulating hormone stimulates the follicles to form gametes, leads to the maturation of these gametes, which are present only in a very primitive form in the unstimulated follicles. So follicle stimulating hormone stimulates them to manufacture these gametes. And we'll have occasion to talk about them several times, particularly tomorrow when we talk about pregnancy. The second hormone that anterior pituitary manufactures is the luteinizing hormone because it helps in formation of the corpus luteum, which we shall see shortly what it is. But in men, there is no corpus luteum, but the hormone is still there. And there we call it the interstitial cell stimulating hormone, or ICSH, because it stimulates the interstitial cells to manufacture these sex hormones. And so FSH and LH have these names depending upon what type of hormones they uh, help in manufacturing. And these sex hormones, in turn, have a negative feedback to the anterior pituitary and to the hypothalamus, as in the case of some other endocrines, as we saw earlier, which means that rise in the level of these sex hormones suppresses the manufacturing of these stimulating hormones from the anterior pituitary, whereas uh, a fall in these hormones would stimulate the secretion of these stimulating hormones from the anterior pituitary. So there's negative feedback. By and large, the feedback is negative, but at one point, the feedback is also positive, which we shall see in a moment. So this whole arrangement is to ensure that the body continues to function normally, and nature seems to have devised mechanisms for making exceptions as and when necessary. The anterior pituitary function, in turn, is controlled by the hypothalamus, and that the hypothalamus does through the secretion of the gonadotropin releasing hormone, or the GnRH. Gonadotropin gonadotropin because it stimulates the hormones which stimulate the gonads as a result of the secretion of hormones from the anterior pituitary. So FSH and LH together can be called gonadotropins because they stimulate the gonads to do something. And to release these gonadotropins from the anterior pituitary, we have a hormone from the hypothalamus, the gonadotropin releasing hormone. And the sex hormones, to some extent, feedback they have a negative feedback effect also on the hypothalamus so far as the secretion of the gonadotropin releasing hormone goes. The hypothalamus, we have seen, in turn, also receives inputs from the pineal through the hormone melatonin. And this is important because apart from other functions, melatonin seems to have an overall inhibitory function on the secretion of GnRH from the hypothalamus. And that is one of the explanations given why sexual development is rather premature, is happening at an earlier age these days when young people are sleeping less at night and sleeping very late, because we saw that melatonin is secreted when we sleep. It is connected to the light dark cycle. And therefore, if one does not sleep enough, particularly one does not sleep enough when it is dark outside, the melatonin secretion will go down. So, as a result of the present lifestyle where one can have an active nightlife instead of sleeping, melatonin secretion would be less. And if less melatonin is secreted, the inhibition of the hypothalamus will be reduced. If the inhibition is less, more of GnRH would be produced, and therefore the gonads would be stimulated more, and that's how these sex hormones would be secreted in larger amounts at an earlier age than it used to happen earlier. So this is one of the explanations, the tentative explanations given why the sexual development or puberty, as it is called, sexual maturation, is happening at an earlier age these days as compared to it happened in the past. And not that everything that was in the past was necessarily better, but certainly we were more in tune with nature in the past. And probably, therefore, it incorporated the wisdom of the body more faithfully, whereas the current lifestyle is relatively short. The fact is that we all have a rather ancient body even in the modern world. And therefore, the body has not changed, we have changed. And therefore, there's a mismatch. And that is what leads to many of these complications. You might say earlier sexual maturation is no problem. So what if instead of having it starting at 15, it starts at 13? So what? But then the fact is that that is not all that is. It leads to many other abnormalities, uh, just such as the polycystic ovarian syndrome. Now, these are all things which then follow because uh, these things are not isolated in themselves. They are a part of an orchestrated mechanism. And therefore, if we disturb one bit, the entire orchestra gets disturbed. And that's how we get these disorders if we do not follow the rhythm of nature. Further, we had seen that the function of the pineal is influenced not only by light and dark, but could also be influenced by stress, because the innervation of the pineal, the nerves that come to the pineal, come in a circuitous manner and they pass through the sympathetic nervous system. Further, the hypothalamic function is influenced by the higher regions, so-called higher regions of the nervous system, the limbic system, which deals primarily with emotions, and the cerebral cortex, which primarily deals with the thought process. So, therefore, thoughts and emotions can influence the hypothalamus. Stress can influence the hypothalamus through melatonin, and stress can affect us also through in this emotional component of the nervous system here. And the result is that our thoughts and feelings can have an important influence, can affect very strongly the reproductive function. And therefore, many menstrual disorders or impotence in men and many other abnormalities can be traced to a disturbance in the thoughts and emotions. So that's how we find that the nervous system and the endocrine system are not really separate. The hypothalamic hormones may be the hypothalamic hormones and the gonadal hormones may be a part of the endocrine system, but then it is intimately connected to the entire nervous system. And therefore, the two are not really separate. And that's how thoughts and emotions can influence a wide variety of endocrine functions, including the endocrine functions of the gonads. And that's how the thoughts and emotions can affect reproductive function. On the other hand, there's also a relationship another way, that is, the sex hormones influence the thoughts and emotions. So the sex hormones affect the nervous system, and the nervous system affects the secretion of the sex hormones. The effect of the sex hormones on our thoughts and feelings is something which we can easily relate to because of the change in behavior, change in the thoughts and feelings that a young person experiences after puberty, after becoming sexually mature around the age of 13 or 14, or a little later, a little earlier in women than in men. But we are familiar with those changes that happen not only in the bodily structure but also in the thoughts and feelings. So these hormones can influence the nervous system, and the nervous system can influence these sex hormones. It's a reciprocal relationship. What is it that suddenly happens at puberty, which leads to this type of a change? This basic structure is there even in a child age 5. What is it that happens suddenly at the age of about 15, which leads to these major changes? Uh, in fact, nobody fully understands what happens, but some of the uh, plausible explanations not fully supported by experiments, are that the gonads are still premature, the brain is premature, the hypothalamus is premature, or the hypothalamus is extremely sensitive to the sex hormones, and therefore the negative feedback is extremely strong at a younger age, and suddenly the hypothalamic sensitivity goes down at that age because of some mysterious process, and that's how, maybe because of the changes in the pineal function, and that's how the now this gonadotropin releasing hormone is not suppressed as effectively by these sex hormones as it is in a child, and that's what leads to puberty. Now, these are some of the plausible explanations, but essentially, we really do not know for sure what happens all of a sudden at that age that leads to those rather dramatic physical and emotional changes at puberty. So you can see here that the basic regulation of the reproductive function is very similar to what we saw in the case of many other hormones. Now, turning specifically to the female reproductive system, this is a pictorial representation, uh, and this is the uterus, the organ in which the baby grows in this cavity, and the gonads are these ovaries, one on either side, and the ovaries, we can see, have some sort of a membrane uh, connecting them to this tube. This tube is an extension of the uterus. This tube is called the fallopian tube. And at the end of the fallopian tube, there's a funnel like structure, but with these finger like projections, they call the fimbri. So, this is the fimbriated end of the fallopian tube. And this fallopian tube then opens into the uterine cavity. The uterus continues as the vagina, and this particular part of the uterus, the terminal part, is what is called the cervix. You might have heard of the cancer of the cervix, and it is this is the region that is affected in that. So essentially, this is the female reproductive system. The two ovaries, which shed the ova or the eggs, and the egg finds its way into the fallopian tube, and then it may meet the male gamete somewhere here, and then it travels into the uterus where the development of the baby continues. This is a more realistic picture of the female reproductive system. The ovaries, the fallopian tubes, and the cavity of the uterus, the cervix of the uterus, and the vagina. This is a side view cut along the midline. And you can see here the uterus overlying the urinary bladder. This is the rectum, and this is the anal canal. So if we go from the front to the back, this is the pubic symphysis, the bone that can be felt in the front in this region. Behind that is the urinary bladder, and this is the passage for the urine. Then behind that is the uterus, continuing as the vagina, and behind that is the rectum and the anal canal. So the three openings, one behind the other, the urethral opening for the urine, the vaginal opening from where the baby is delivered, and the anal canal through which we get the stool. And as we were talking the other day, the urine is clean in terms of bacterial population. It's sterile, essentially sterile, whereas there can be germs, most of them friendly, but some of them not so friendly in the vagina as well as in the rectum. And therefore, to ensure hygiene, one should wash from front back, not the other way around. Uh, that will prevent the infection of the urinary tract so that the germs from the backside will not be able to enter the urinary tract. Now we turn to the menstrual cycle itself, and for that, I'll turn to the digital board. Aditi, is it possible for you to change my view so that less of the screen is covered?
You can just minimize the view. On the right, you will be seeing a lot of our
Okay.
windows, no, small, small. So
Yes.
just click on the minus button.
Yes. Thank you.
Okay.
As you can see, I have shown here the days 1, 4, 7, 14, 21, 28, the days of the cycle. Menstruation lasts about 4 days. So we can say that from day 1 to day 4 is the period when menstruation takes place. And the shedding of the ovum takes place around day 14. And 28 would be the end of this cycle and the beginning of the next one. And therefore, from day 1 to day 4 would be the menstruation for the next period. So, and what we'll see as we go along is the changes that take place in the uterus, the ovary, the hormones, estrogen and progesterone, and LH and FSH secretion from the anterior pituitary. And these are not the only changes that happen during the menstrual cycle, but these are some of the key changes that help us in understanding how this cycle is actually generated, how it happens. Now, let's start with the ovary. And let's start after day 4, when the follicle, which was rather immature and small, starts growing bigger, starts maturing, and around day 14, it releases the ovum. So this is the egg, which is which will travel towards the uterus, and what is left behind is what we call the corpus luteum. And by day 28, this corpus luteum also degenerates, and what we are left behind is basically a scar left behind by the corpus luteum. So this is the fate of just one follicle, which develops, releases an egg, becomes the corpus luteum, and the corpus luteum also forms a scar. So this is the type of change taking place here. Uh, the number of follicles in the ovaries, uh, the two ovaries put together, may be about 1 million. But out of these, only about 400 uh, can be active follicles. Say if we consider one follicle a month, 12 in a year, and the reproductive age to be about 35 years, say from age 15 to about 50, comes to about 400 ova. So 400 ova will actually can develop like this at the most. And to start with, there may be one ovum which starts maturing, but finally only one will actually most of the time develop like this during each cycle. Now, how is it that that happens? And what are the corresponding changes taking place in the uterus? Now, what happens in the uterus is that during the menstrual cycle, it is shed, and we will not show it in great detail here. But as the follicle develops, this follicle starts secreting estrogen. And in the influence of this estrogen, the damage that was done during menstruation to the uterine wall starts repairing, and the uterine wall starts getting thicker. And as it gets thicker, it will need also more blood. And this blood supply, so the blood vessels also develop. There's some secretions which are necessary. Some glands also develop. Uh, and then we find that the development is accelerated considerably here. And how this happens, we'll see as we go along. Now, all this is happening under the influence of hormones, the hormones which are being produced by this follicle itself. And which are these hormones? To start with, estrogen. Now, the estrogen develops, estrogen is secreted by this follicle. So the level starts going up. And the follicle develops under the influence of the follicle stimulating hormone. So this level also goes up. But then as this estrogen is secreted, it will have a negative feedback effect. And therefore, this follicle stimulating hormone may start coming down. But then something dramatic happens around day 11. Around day 11, what happens is that instead of a negative feedback, the estrogen starts having a positive feedback on FSH, which means FSH level starts going up. And reaches a peak around day 14. And corresponding to this, we find that the estrogen level also reaches a peak around day 14. And what about the LH? Now, this is a somewhat mysterious process in the sense that the LH levels are low, but then a little before day 14, there is a sudden increase in the LH secretion. And it is this LH surge which corresponds to the release of the ovum. While I mean both these are going up, the FSH and the LH, and both may be contributing to the release of the ovum from the ovarian follicle, it has been related more to the LH surge than to the FSH surge. And then what happens is the negative feedback takes over once more, and the LH levels come down. the and after the ovum has been released, the corpus luteum that is formed, that secretes progesterone. And therefore, we find that now the progesterone levels start going up. And then as the FSH and LH levels come down, the progesterone levels start going down. And in the same way, because of the reduction in the FSH levels and LH levels, the estrogen secretion also goes down. And the withdrawal of these hormones, estrogen and progesterone, leads to the degeneration of the corpus luteum. And corresponding to this, what we find in the uterus is that under the influence of the estrogen and the progesterone, particularly progesterone now, there's a further development. So while the height of the uterine wall may be about 3 millimeters at that will before ovulation, it reaches up to 6 millimeters at the peak. And then what happens is that the withdrawal of these hormones can't support this development of the uterus anymore, and there's a breakdown of the uterine wall, and that's what leads to menstruation. So the hormones have come down, the source of hormones has disappeared because the corpus luteum has become a scar tissue, and these hormones were required for maintaining the uterine wall in that thick and well developed state, and therefore this has come down. Now, what is the wisdom behind all this? The wisdom behind all this is that the development of an egg is preparation for pregnancy. And for pregnancy to happen, not only we need the shedding of the egg, we also need preparation of the uterus, because where the baby has to grow. And the abode of the baby, if it comes, is being made ready to receive the baby. And that's how this uterus, which had undergone a lot of breakdown and damage during menstruation, is being repaired and developed into a structure which not only has a soft, comfortable, uh, thick sort of mattress, but along with that, it also has the necessary blood supply, and therefore blood vessels are growing, and these blood vessels which grow in the thickened are tortuous. They are tortuous because as the baby grows, the uterus will expand. The baby will need, and if this expansion has to take place in spite of the blood vessels breaking, they should also be tortuous. So tortuous blood vessels giving the uterus a reddish glow, and the glands which will manufacture the secretions which may be required for maintaining the growing baby. So those glandular secretions increase, and these blood vessels develop, and the wall becomes thick. So we have a thick mattress and a red carpet lined here to receive the baby. That's a sort of a red carpet welcome is being arranged for the guest to arrive, because the fertilization will take place soon after this egg has been released. If there's fertilization, it will happen within a few days of the egg being shed. Uh, but then, if that does not happen, then we find this is how the uh, negative feedback of the estrogen and progesterone will lead to a drop in the FSH and LH, and drop in the FSH and LH, and the drop in the estrogen and progesterone means that this hormonal support of the uterine is withdrawn, and when that is withdrawn, the corpus luteum, the maintenance of which depends upon the luteinizing hormone, will start degenerating. And when these hormone levels come down, no longer much of progesterone to support this growth, the uterine wall starts breaking down. And we have the menstrual bleeding. So this is how we can understand this. And one way of looking at this, poetic way or philosophical way of looking at this has been that here there was a welcome arranged in anticipation of the baby, but when the guest does not arrive, there is disappointment and frustration. And it's this disappointment and frustration which may also be responsible for the premenstrual syndrome, which some women experience during this period, a few days before the periods are due. Uh, it, uh, they have they go through a sort of emotional changes which are described as premenstrual syndrome, which we'll talk about a little later. So those emotional changes express that frustration. And in terms of the structure, the uterus breaking down is also a part of that frustration. And therefore, menstruation has sometimes been described as the tears shed by the uterus because the expected guest did not arrive. But then, and like an untiring host, it doesn't give up. It starts the next cycle all over again, starts the preparation with a new egg all over again, perhaps in the hope that this egg will now get fertilized. But then the fact is that although this may happen 300 or 400 times in the reproductive phase of a life, uh, there are relatively very few eggs which actually uh, get fertilized. So this expectation of the egg to get fertilized and the preparation of the uterus is something that remains redundant for most of these 400 cycles. Very few of them actually lead to what it has been prepared for. The arrangement has been made, but all the same, this doesn't happen most of the time. Now, one might say that how about the control from the hypothalamus, which has not been shown here? Now, it is the hypothalamus which is further controlling the FSH and LH through the GnRH. Now, how is it that GnRH being a single hormone is able to regulate the secretion of both FSH and LH? Uh, Now, here we find that another ingenious device of nature, that while GnRH is only one hormone, the hypothalamus produces GnRH, the gonadotropin releasing hormone. There's only one hormone, but it's able to control the secretion of two because of the pulsatile nature of its release. GnRH has a pulsatile release, and it's the cyclicity of the GnRH release which seems to be regulating the cyclicity of this entire process. And since two hormones are involved, we find that the pulsatile release, which leads to the secretion of FSH, which controls the secretion of FSH, here has a higher frequency. So the pulses are released at a higher frequency for stimulating the secretion of FSH from the anterior pituitary, whereas when it comes to the secretion of LH, the pulses are more widely spaced. So the frequency of these pulses is what determines whether GnRH will stimulate release of FSH or it will stimulate the release of LH. So you can see that nature has these ingenious devices uh, so that the type of code that we have in the hypothalamus is of a different type. It doesn't depend upon the levels of GnRH. Of course, the levels are affected negatively by the gonadal hormones, but it doesn't depend upon, also it is affected negatively by melatonin. But the secretion of these two hormones, FSH and LH, is being regulated by the same hormone, GnRH, because of this variation in the frequency with which these pulses of GnRH are released from the hypothalamus. So when it is secreting GnRH, again, it is not a steady secretion, it's a pulsatile release. And the frequency of the pulses determines which of these two gonadotropins, FSH or LHS, would be stimulated. And further, then we have, of course, seen that this is under the influence of thoughts and emotions, both directly from the nervous system and from the pineal, the melatonin coming from the pineal. So you can see this entire thing is pretty complex and well regulated. Now, we have shown only a few structures where these changes are taking place in a coordinated fashion: the uterus, and the ovaries, and uh, the hormonal levels from the ovary, from the eggs or the corpus luteum, and the FSH and LH secretion from the anterior pituitary and GnRH from the hypothalamus. Apart from this, there are changes at other places also, at particularly in the breast, where the secretion of estrogen leads to some basic increase sort of in the structures in the breast, which are further accelerated by progesterone. One might say that what estrogen does is to equip the breast with the nuts and bolts for manufacturing milk. What progesterone does is to actually assemble those nuts and bolts to uh, make the factory ready for production. And if the milk production is actually required, then another hormone from the anterior pituitary, prolactin, will initiate the production process, and the production of milk will actually start. The production will start, but for releasing it, we need yet another hormone, oxytocin, which will come when the baby has actually arrived and suckles the breast. So we have that development going on in the breasts, so that it is well coordinated with the requirements of the baby. And then we have other changes which may not be so obvious, like, say, changes in the pelvic musculature and ligaments, so that they relax at the right time, and the baby can be delivered. There are changes which take place in the cervical mucus, which keeps it by and large hostile to the entry of spermatozoa or the sperm. It remains hostile to the entry of sperms throughout the menstrual cycle, except for a few days after ovulation. So that is when it allows that, uh, so that the sperm will be able to enter easily, only when they will be able to fertilize an ovum. So these are some of the changes that are taking place, which are not so obvious, but you can see that the entire process is extremely well coordinated and affects so many structures in the body, so that if pregnancy takes place, it can go through smoothly. And if it does not take place, then of course we have this menstruation, representing in a way that frustration because the expected guest did not arrive, and then the process starts all over again in anticipation of the next guest. So with that, now we can again go to the slides. Now here you can see the LH surge, which is thought to be responsible for the ovulation. So this is the day of ovulation, around day 14. So this is the ovary where the follicle is developing, within which is developing this egg. And around day 14, the egg is released, and what is left behind of the follicle develops into the corpus luteum. So these 2 days are the most fertile days, and the rhythm method of contraception depends upon this. The menstrual cycle is not always exactly 28 days. In fact, varies quite a bit from about 3 weeks to 5 weeks, or sometimes even more. Could go to 40, 45 days also. But the period that is relatively constant is the period after ovulation. This is relatively more constant. This is the more variable period. And therefore, it is sometimes important to know the day of ovulation. If a couple is following the rhythm method of contraception, then for them to know the day of ovulation is important. And one of the indications that comes is from a small rise in the body temperature. So, uh, if one takes the temperature early in the morning, one finds that there is a rise just around the time of ovulation, and that the person knows that now ovulation is likely to happen very soon within the next day or two. And this rise in the body temperature is one indication. There are also kits available for prediction of ovulation, and they depend upon the detection of the LH surge. So as the LH goes up steeply, those kits can give us a positive result. So that's how the day of ovulation can be, to some extent, predicted, in spite of this period being rather variable. Now, this is a beautiful picture of the a picture that I tried to draw on the whiteboard. The advantage of that I saw was that you could see the whole thing evolve gradually, and that sometimes is more effective than seeing the whole picture ready-made as you see here. But in this picture is certainly much more beautiful. You can see the changes in the ovary and the ovulation taking place around day 14. And corresponding to this are these changes in the hormonal levels. Uh, the This faint yellow is the progesterone level. This is when the progesterone secreted by the corpus luteum goes up. And this is the FSH surge, which corresponds to ovulation. And this is the LH surge. So the LH surge and the FSH surge are what give us the what corresponds to the ovulation, correlates with the ovulation. And this is the estrogen secretion. Estrogen secretion, which is low from a primitive follicle, rises as the follicle matures. And in spite of the negative feedback for some time, the level continues to rise because the for developing follicle is growing bigger, is capable of secreting more. So in spite of the negative feedback, the level continues to rise, and then the rise becomes steep uh, around day 11 because of the positive feedback on FSH and LH. So it's around day 11 that this positive feedback leads to this peak. Initially, you can see the FSH levels are falling because of the negative feedback, this green one. The FSH levels, the green one, is falling because of the negative feedback. But then, in spite of that, the estrogen levels are rising because the follicle is growing bigger and is capable of secreting more of estrogen. So, in spite of the negative feedback, the level continues to rise. But then, around day 11, there's a dramatic change, which leads to uh, a further acceleration, this peak. And along with that, there is also uh, perhaps a positive feedback on the LH. This LH surge may also be because of the change in the nature of the pulsatile release of GnRH from the hypothalamus. And the result is that we have both these peaks, FSH and LH peak or surge, as it is called, corresponding to the ovulation. And now that the structure has been changed, instead of the follicle, the egg has been lost. What is left behind is the corpus luteum. The corpus luteum is equipped to secrete uh, progesterone rather than estrogen. So you find a rise in the level of progesterone. The rise in the level of estrogen is rather modest. So modest rise in estrogen and a remarkable rise in progesterone because of the hormones secreted by the corpus luteum. Now, the corpus luteum, these hormones have a negative feedback on FSH and LH, and therefore those levels are now going down. As these levels go down, the corpus luteum can't continue to secrete estrogen and progesterone. So estrogen and progesterone levels go down, and as these levels go down, they can't maintain the corpus luteum. The corpus luteum degenerates, and in turn, the fall in these hormones can't maintain the uterus. So the uterus uh, starts winding up. The structures that were put in place in anticipation of pregnancy get dismantled, and that dismantling leads to the menstruation. After day 28 begins the first day of the next cycle, when that breakdown shows up as dismantling of this whole process shows up as menstrual bleeding. Now we come to the premenstrual syndrome, the discomfort that many women experience a few days before the periods are expected may start about 1 week before the periods and lasts about 5 days. And other things associated with it are the pimples, acne, particularly on the face, feeling tired, irritable, mood changes, headache, and loss of sleep or insomnia. All these changes of premenstrual syndrome get worse on a high salt diet, caffeine, and alcohol. Caffeine in tea and coffee, and alcohol. And therefore, the treatment of premenstrual syndrome corresponding to this is uh, avoiding these things, avoiding a high salt diet, avoiding tea and coffee, avoiding alcohol, and physical activity. It improves with exercise. And knowledge of this entire process can also help, because the person understands the process. The person is less likely to feel irritable or have these mood changes. Then menopausal symptoms, which happen because of the hormonal withdrawal, because after the age of about 50, and in fact, the process starts around the age of 45, the hormonal secretion from the ovary goes down, the estrogen and progesterone levels go down. And because these levels go down, FSH and LH levels, FSH and LH production in the anterior pituitary may actually go up. So a combination of these low estrogen and progesterone levels and high FSH and LH levels is a characteristic of the menopause. And what the woman experiences around this age is irregularity of periods. To start with, they may get irregular, and the amount of bleeding may also be less sort of predictable. It may become very little, sometimes heavy bleeding, and there may be hot flashes felt on the skin. The skin feels warm, particularly the face, and mood swings, loss of sleep. Uh, the sex hormones, estrogen and progesterone, to some extent also help in maintaining bones in a good shape, and therefore there's reduced bone mineral density, which in turn increases the susceptibility to fracture. A little fall and the woman might get a fracture. So reduced bone mineral density. And the best treatment for this, preventing this particular process, osteoporosis, that is unhealthy bones, is something that this prevention has to begin early in life, because it's early in life, during childhood and youth, that we can deposit uh, appropriate amounts, the right amounts of calcium in the bones, and may keep the bones healthy. After that, one may be able to reduce the loss, but one can't promote further deposition easily. And therefore, the prevention has to begin early in life. And apart from the calcium, uh, which would help, taking enough of calcium in early life, and vitamin D, which helps in absorbing and utilizing this calcium. Apart from this, what is also important is regular physical activity, particularly weight bearing activity, because that is what helps in depositing calcium in the bones rather than uh, just any physical activity. So, weight bearing activity, and not indulging in things such as smoking, particularly. So, smoking, lack of physical activity, and deficiency of calcium and vitamin D, particularly vitamin D, These are some of the important contributors to not having strong bones in youth, which in turn will show up through an increased risk of fracture in old age, more in women than in men, because this type of hormonal withdrawal takes place primarily in women. Men continue to have fairly good hormonal secretion till old age. So women are more susceptible to this. The treatment of these menopausal symptoms is, to some extent, you can say, addressing these physical changes by giving some vitamin D, calcium, and some other drugs which may help in depositing calcium in the bones. Uh, but and also sometimes one tries to go in for hormone replacement therapy. That is, the levels of hormones are falling, so therefore we give hormones from outside. That is hormone replacement therapy. But then the value of this is questionable. Firstly, it cannot be continued indefinitely because that carries its own risks. Secondly, uh, it is something which is unnatural and therefore may disturb the usual process of uh, advancing age, and which also has its wisdom packed in. And we cannot just tamper with one part and expect that everything will be corrected. The person will still continue to grow old. So, hormone replacement therapy is something which uh, is controversial. And if at all it is given only in extreme cases and for a few years, not indefinitely. So it's a short period for which it is given and given only when absolutely necessary. But then what is most important is that the woman sometimes also has many of these psychological symptoms like mood swings and loss of sleep and so on, which are in a way the most troublesome because she starts feeling that now I'm growing old, I'm growing less attractive. I will. She starts feeling that she may not be loved as much. She may not be wanted as much. She is losing physical strength as well as this uh, sexual function or reproductive function. So, what is important is to that the people around her uh, accept her as she is, accept this as a normal process, and all her near and dear ones, particularly the partner, needs to understand this and reassure her that she continues to be just as loved and wanted as she always was. This minor change, which is relatively a minor change, actually does not matter in how much love and concern and affection she receives from those around her. But this is something which is, in fact, a part of our culture, the Indian culture, because in India, we don't consider an old person to get sort of redundant because the person cannot uh, do this or that. Reproductive function is only one of the things that the old person cannot do uh, as well as a young person can. In fact, the um, general abilities of a younger person are much better than that of an older person. Aging essentially is a decline in all the functions. This may be one of the more obvious changes or changes which women may feel concerned about, but in general, all abilities are declining. But these declining abilities are not considered the reason for not looking upon this old person with the same concern or the same degree of respect. In fact, this person earns greater respect because of the wisdom that this person might have accumulated over the years. That is more natural to the Indian culture than to consider this person redundant because the person is now becoming incapable of doing many things. And correspondingly, the word that we have for an old person in Hindi and Sanskrit is vridh. Now, vridh means Vriddha means it comes from growth. Vriddha means the one who has grown in every respect, particularly wisdom. So, an old person is not old in the sense of having become uh, incapable of doing things because an old, let's say, an old car doesn't function as well as a new car. So, their old has a negative connotation. But when you say that the car has not grown old, the car has grown vrid, that it has grown, then it changes our way of looking at the old car. Now, well, I mean, the car having grown in wisdom may be questionable, but an old person is considered to have grown in wisdom and therefore is called vriddha rather than uh, look upon this old age with a negative connotation. And this is something which perhaps is responsible for the women who live under more traditional surroundings and have a more conventional attitude to aging. They can accept this change of menopause also much more easily, and they continue to remain comfortable. But if there is any sort of feeling of inadequacy in the woman, this has to be uh, this has to be sort of corrected through reassurance by those who are near her, by telling her that she will continue to be just as loved and wanted as she always was, uh, in spite of this minor change, which is normal, natural, and physiological. And why that happens, that also one can understand, because bringing a baby into the world is only a small part of parenting. After that begins that long process, which may go on for the next 20 or 30 years, which can be quite taxing physically as well as emotionally. And as all the bodily functions are declining in old age, the person is not really equipped to put in uh, all that hard work, physical and emotional, which is required for bringing up a child from a newborn baby to a young person who can stand on his or her own feet. And therefore, since the person will not be able to do that, it's better not to have the child at all. And that is why nature has ensured that a woman will not be able to conceive after a certain stage when she will not have the energy to take care of a young one for the next 20 to 30 years. And realizing this uh, thing, which is an inevitable part of the life cycle, the those around her have to reassure her that while this function may not be possible, she still continues to be a valuable member of the family. She can still contribute in many ways, many other ways, and she will continue to be loved and respected and wanted. Now, coming to the polycystic ovarian syndrome or the polycystic ovarian disease, uh, here some of the features that we find are that there may be ovarian cysts. Cyst, is a balloon-like structure. Uh, these are nothing but the follicles which have grown into these balloon-like structures. And the periods become irregular, uh, and there's no ovulation, and the androgen levels may be high. Now, these androgens, that is male sex hormones, come from the adrenal glands, and also in these girls from the ovaries, because after all, the difference between male and female hormones is relatively small. The precursors are still the same, and the precursors have to be converted into androgens and estrogens. And something going wrong with this process can lead to production of androgens also from the ovaries. So the female hormones go down, androgens go up, and that's what leads to the derailment of the normal periods and formation of these ovarian cysts, because the follicles can't develop normally and shed their eggs. Instead, they develop these cysts. Now, any two of these features are enough for diagnosing a person having a polycystic ovarian disease. And the basic cause is high androgen levels and tends to be often associated with overweight and type 2 diabetes. If not type 2 diabetes, at least impairment of glucose tolerance. That is uh, early stages when person is not frankly diabetic, but is moving in that direction. The person is not able to bring down the blood glucose levels adequately after a meal. So after a standard meal, the blood glucose levels are higher than would be considered normal. They may be within the normal range, but still they are towards the upper end of normal or slightly above that. So that is impaired glucose tolerance, which can be considered sort of a warning that the person is at a high risk for developing type 2 diabetes. Type 2 diabetes is the maturity onset diabetes, uh, which takes place usually around, which may happen around 50 in some people. But these days, the tendency is for those who are at risk for diabetes to develop it at an earlier age because of the unhealthy lifestyle. So it's associated with overweight. Type 2 diabetes may also be associated with other things like raised cholesterol levels, uh, impaired thyroid function, fatty liver. Now, all these things tend to form a cluster, and the person may have more than one of these present together. But focusing on the polycystic ovarian part, the principal factor responsible seems to be high androgen levels, that high levels of male sex hormones, which come from the adrenals and the ovaries. And associated problems could be, and generally are, overweight and type 2 diabetes or impaired glucose tolerance. Now, all these are in a way, and the other cluster of diseases with which they may be associated are lifestyle diseases. And therefore, the treatment is adopting a healthy lifestyle. A healthy lifestyle is that in which there is regular physical activity, half an hour, at least half an hour or so, half an hour to 1 hour of brisk walking or an equivalent exercise. Yogic postures are better than other types of exercise, but any exercise is better than no exercise at all. A healthy diet taken in enough quantity with the right attitude. So, what we eat, how much we eat, and how we eat are all are important. Then, not putting into the body any harmful substances like tobacco and alcohol. And just as in case of food, taking care of sleep, uh, when we sleep, how long we sleep, and how we sleep, all are important. And then, above all, being mentally at peace. Now, these are some of the lifestyle changes uh, which would help in treating polycystic ovarian disease. And apart from this, a drug that has been found fairly useful is metformin. It's also used in type 2 diabetes, but it can be also used for polycystic ovarian disease. It helps the person lose weight, prevents the development of type 2 diabetes, and improves fertility. But then they should be taken only under medical supervision or medical advice. Suggested reading, where you'll find some of this material, are this popular book, The Human Machine, and these two textbooks, Fundamentals of Physiology and Understanding Medical Physiology. Another book that you could read is this Principles of Anatomy and Physiology by Tortora and Grabowski, which has been used also for the anatomical pictures in this presentation. Gratitude to the mother and Sri Aurobindo for making these sessions possible. And thank you all for being there. Are there any questions in the chat?
There's just one question. What is the role of folic acid for women?
Folic acid deficiency is pretty common in India because of inadequate intake of green leafy vegetables. Folic comes from foliage. So, it's because it's abundant in green leafy vegetables. It's called folic acid. And this deficiency is quite common because of inadequate intake of leafy vegetables and fruits, particularly green leafy vegetables. And it's important for everybody to prevent folic acid deficiency anemia. But in women, it becomes especially important because it has also been seen that if a woman is folic acid deficient, then she has a greater possibility of delivering a baby with congenital anomalies. And therefore, during pregnancy, it is particularly important to keep that in mind. And therefore, the supplements which are given during pregnancy invariably have not only iron but also B12 and folic acid.
Sir, I'm good morning, sir. So I'm like 43 and I'm getting since 3 months, I'm getting periods, almost two periods in a month, like sometimes 15, sometimes 20 days, sometimes 90 days. So is that can be a symptom of premenopausal symptoms? But my mom said like she was done with her menopausal by 45. So, but I am quite a active person, do yoga, and like I am level 3 yoga instructor from Ayush department. So I teach yoga and I do dance and I participate in other things. But at the same time, like I'm getting these symptoms. So I was little so in before I was never having any irregularity. So was just thinking what it can be.
This could be the beginning of menopause, and the age is variable. And uh, many things in our body tend to sort of follow a pattern which our parents had. So, as you said, I mean, your mother also had menopausal symptoms relatively early. You're also getting them a little early, but then uh, that is variable. So long as the bleeding is not very heavy, it's not leading to anemia. The change in the cyclicity by itself should not worry you.
Okay, sir. So it should like if it continues like that, so it if the bleeding is not heavy, so it should be we should consider it normal.
Yes,
Okay.
because I mean, as you said, I mean, and this it could start a little earlier in some and a little later in other women. And as you said, I mean, your mother also had a similar experience. So these things tend to follow a pattern because this, I mean, it's amazing, but at the same time, the blueprint that we carry in our genes can influence so many things, including uh, the rate at which we age and the type of diseases that we may develop. These are all things which are because of are just repeating the uh, pattern which our parents had.
One last question in the chat box. What effect does an early hysterectomy at the age of 35 years has on a woman's body?
Generally, when hysterectomy is done at such an early stage, uh, the ovaries or at least some part of the ovaries left behind, and therefore the hormones continue to be produced, and therefore nothing else needs to be done. One just has to feel assured that removing the uterus uh, does not mean that the other functions have suffered. It's just that I'll not be able to conceive, but apart from that, everything else remains normal. But if due to some reason the ovaries have also been removed, then some hormone replacement may be necessary for a few years in a young woman. That's about all.
Okay, that is all the questions we have for today. So maybe we can close the session with a moment of silence and thank you everyone.